And good afternoon. It's Dr. Deuk at Deuk Spine Institute. We are broadcasting our spine surgery today live. We've already had one surgery done and the patient's almost ready to go. The last one we did, the 4-level Deuk laser disc repair, he's already dressed and actually on his way out the door in a few minutes. This next surgery is a lady who you're going to see, if you haven't seen already, in a moment with the x-rays. Basically, she's had extensive surgery, the kind of surgery I tell you folks avoid. And she didn't know any better. Her surgeon recommended a multi-level fusion. And you can actually see in this x-ray, I'm going to bring up the x-ray now. Go ahead and, can you see the x-ray, Henry?
Yes, we can.
So you can see the screws in S1 are loose. And show us the cavity. The loose cavity, there it is. You see the gray line around the screw? That's how loose they are. Massively loose, both sides. Show them the other side. All right? So this didn't work. The fusion did not work at L5-S1. Now, if you look above L5-S1, just show us the fusion mass. Yes, see all that bone up there? Jordan is outlining it. All that stuff over there is called the fusion mass. Now, that did fuse, and that's L4-5, L3-4, and above. But the L5-S1 didn't fuse, and as a result, the screws got loose. This patient has horrible pain. Now, I believe her pain could be related to her facet joints at L5-S1. Because there's movement, that means the facet is moving. If the facet's moving, it could be painful. So I want to treat the facet joint because I believe that's the source of her pain, despite the fact there's loose screws. Show us our targets today. It's very difficult to hit the targets because of the bone formation. It's going to be really tough. But there's one target at the S1, and there's the other target at the L5. So that's what we're going to go for. Let's hope it works. If it does, then she can avoid having to have a revision of her fusion. And we're going to be treating her facets. The first thing I have to do is get there. I can already feel bone. How's blood pressure? All right. What is that?
That's just infiltration.
Is it?
Yeah.
All right. Where's my shot? Is that it? Okay. So I want to start with L5. A lot of scar tissue. Probably too low. Shot. All right. I may need to be a little bit higher on my entry point. Yeah. So this patient had a surgeon who did her surgery, the fusion, and as a result of that, she has almost her entire spine fused. Shot? That's better. And as a result of that, she's in chronic pain. But particularly she's in pain where the L5-S1 facet is, which is why I want to go treat that and hopefully eliminate her pain. So let's try. All right, let's do our infiltration. We're pretty darn close. I'm going to make sure I get the whole area though.
Yeah?
Mm-hmm. So we're going to make our first incision. And the surgery you're watching today is called the Deuk plasma rhizotomy. And what we're doing is we're actually using a powerful surgical device called an electrocautery device that is going to help us define and destroy the pain nerve that causes back pain that comes from the facet joints. And that nerve lives right in this area, right where unfortunately the fusion mass is. So I'm going to come down to the fusion mass and I'm going to try to target at the junction of the transverse process and superior facet. And I can feel the bone. I'm going to try to target the nerve, the pain nerve. This is not the same as a nerve root. A nerve root we want to preserve. You never want to harm a nerve root. Nerve roots are these very delicate structures that carry motor and sensory information from your legs and your feet all the way up to your brain. We don't want to hurt the nerve root. We want to get rid of the pain nerve that lives in the back of the spine. And that pain nerve is what's responsible for transmitting pain signals from the facet joints up to the brain. Therefore, if we eliminate that nerve, and that's a standard medical treatment, by the way, it's not something that we developed here. The procedure whereby you eliminate the pain nerve is called a rhizotomy, or dorsal medial branch of the dorsal ramus rhizotomy. And that's not something Deuk Spine pioneered. That was pioneered by somebody else. What we're pioneering is a new technology that can kill that nerve better, better than what's called a radiofrequency ablation, which is this usual treatment nowadays. All right, that's it for L5. So we're hoping that by applying a new technology that will have a better chance of eliminating her facet joint pain that she has. But again, you have to target the exact perfectly right spot. You guys see it? Show them the perfectly right spot I'm aiming for. Shot? I'm pretty close, but I'm not there. You see how close it is to the actual loose screw, right? Shot? I'm almost there. I'm inching my way, not even inching. I'm millimetering my way north. All right, that should be good right around there. We're going to put some medicine, numbing medicine, then I'm going to go in there and deaden the pain nerve in that area. So if I'm right and this works, then this patient should be able to avoid any more surgery on her back, because yes, I recognize the fact she's got loose screws, but lots of people have loose screws and they don't get surgery for it, and they do fine. Shot? And the reason is because the loose screw is not the source of the pain. And not in everybody. Shot? All right. That's really good position. Let's see. Need to be on the bone because that's where this nerve runs. Shot? That's pretty perfect right there. Wouldn't you say, George? Luis? So it just happens to be that that nerve we're talking about runs in the same place as her loose screw. Shot? Which is why it's really easy to believe maybe it's the loose screw that's the problem. But the problem with that is I've seen a lot of people with loose screws and they don't have pain from the loose screws. So we don't treat it. I'm not going to treat a problem that isn't a problem. I'm not going to treat something that just looks bad. I'm going to treat something that is bad. All right, well, I feel there's a lot of bone graft in there, but I feel like based on the imaging, we've achieved what we needed to do. Let's hope that does it for her. We're going to go to the other side now. Pretty close, a little more. Maybe move it towards me. The base, yeah. Shot. I wouldn't do so much that. I just slide the whole base towards me. Yep. That should open up the window. Almost there. A little more base slide towards me. Remember, we have to get across the whole spine. That's pretty close. A little bit more base slide towards me, and may need a little more rotation. Let's see, but let's try. Shot. All right, let's see what you can do to make that open up there. Shot. I don't know how much more you can do, but maybe it's just a lot of scoliosis. Try a little more orbit. That's almost there. I think that's pretty damn close. Yeah, I think that's as good as we're gonna get it. What do you think? Yeah. Yeah, you can see how orbited we are. So let's try this. I'm gonna start by going up to L5. Shot. So Luis, the reason I don't need so much, you know, of the coker is that there's so much scar tissue.
Yeah, stay there. Hold the needle in place.
Shot? Oh yeah. The amount of scar tissue that's here is incredible. I may have to come more laterally. Shot? That looks almost really good. I mean, I feel the bone. Shot? Try that. Yeah.
Yeah.
So the transverse process we're aiming for is actually fused to the transverse process above. Show them the fusion mass. So outline the normal transverse process. Yep, that's it. And then show them the fusion mass, attaching it to the one above. Come down. Right. Up. Stop. Right there is where the fusion mass begins and it goes up. Show them up. That's it. So that's what we are.
You wanna only the tip on this one?
Let's see. No, let me have it. Shot.
Thank you, Yoda. That helps.
That's not bad. We definitely head in the right direction. Almost really good there. Shot. That's close. Need to be a little more north. That's close. I feel bone. I'm going to go ahead and make my first burn here. Let's just see where that is. Hold on. Shot. It's more lateral than I want to be. Shot. That's better.
Sarah. Over there, steady street, vein soil, and yeah. Thank you. On 2x2.
Let's see where this is. Shot. That's 2 medial. Shot.
Thank you.
That's really pretty good right there. I know it's hard for you all to see what I'm doing, but I'm aiming for the area where that pain nerve would live normally and trying to get it treated by burning it, destroying it. That's what a rhizotomy is. Shot. It's really, I don't think you can do better than that. I'm happy with that. I think we've done a good job. Hopefully that does it. Last one. So we're going to go for the bottom one, the dorsal ramus of, what is it, S1? Shot. All right, 2 medial. Got to get more lateral. The reason why I have to go so lateral is her spine is really rotated. Shot. She has some pretty bad scoliosis at this point. Shot. A lot of scar tissue. Shot. It looks like I'm heading in the right direction, right? Yeah. It's tough. Massive scar tissue. That's about as good as I'm going to get it. Go ahead. So this procedure we're doing is called a rhizotomy, and it is the type of rhizotomy that you would think normally would be done with what's called an RFA. However, an RFA won't work for her because an RFA uses a very skinny needle that doesn't make much of a burn. It makes a very small burn. And this wand shot that I'm using will allow me to make a bigger burn shot. And that's what we need for her, is a bigger burn field. And really for everybody, because the problem with the regular rhizotomy is they wear off. Shot. Feel like that's going into the screw hole. Shot. Almost done, Dr. Berndes. Another minute. Is that it right there? Shot. Shot. Trying to work my way over just a little bit more medial. Just about done. Shot. Good job. Let's hope this works. I feel pretty good. The last one, not as good about, but because there's so much bony remodeling, the normal bony anatomy where the nerve is found has been completely disrupted, but I could feel the bone in that area. I stayed on it. I moved medial to lateral with the tip, and I feel like we got a good burn. So it's as good as I can do. It's her best chance of avoiding a big revision surgery, which is what she would need. You can see everything is done through two tiny little marks. And we put a little bit of medicine in there to make it more comfortable. She's under some anesthesia. But you can see the scar from her old surgery. It just goes all the way up to the middle of her back. All right. No, we're good. All right, any questions?
Yes, we have 2 questions.
So you'll do steri strip closure,
Yes.
a little pressure bandage?
Yes, sir.
All right, yes, we'll take the questions.
This first one comes from Oz on YouTube
Hello, Oz.
and asking, what happens if a level doesn't fuse within the first 3 months or year?
If a level doesn't fuse in the first 3 months or year, it's probably not going to fuse at all. Just because you don't fuse doesn't mean that's the cause of your symptoms. I've seen hundreds and hundreds of non-fuse levels after undergoing spinal fusion, and the patients have no symptoms from them at all. So if we took 100 patients with a non-fuse level, the chance that that level is causing their pain is less than 5%. It's usually something else causing the pain. That's why you need an expert to figure it out, like me.
And last but not least, we have a question from Jay Mora on YouTube.
All right, Jay, we'll take your question.
And they asked, do you have to have payment up front for these procedures? Is there a deposit I can make and maybe a payment plan? I do have Cigna PPO plan.
Yeah, so to answer your question, great question. As far as payment goes, it depends on your insurance. And everybody's insurance is different. Some insurances pay the whole bill, and we have a contract with them. They're going to pay the whole bill. We don't take any money from the patient. Other insurances, and this is most of the time, other insurances won't pay the whole bill, or we don't have a contract, and the patient has to pay some money up front. So to know exactly with Cigna PPO, they're usually pretty good, but you will have to pay some money up front. How much you pay up front depends on what's being done. So everybody asks me, how much? I don't know how much it's going to cost. What we need to do is a MRI review and virtual consultation. All that's done from the comfort of your home, your phone, work, wherever you are. I have people that do this from all over the world, all over the United States, from California to New York, New Jersey to Louisiana. I mean, everywhere. And we do these every week. It takes 10 minutes. I can look at your MRI. I can look at you on your exam during the Zoom call, and I will know exactly what's causing your pain once I see you and the MRI together. But that's only done through a virtual consult. So my advice is use our virtual consult link, get your diagnosis first and treatment plan, then worry about pricing.
Alrighty, and one more question. This comes from Fred Rudolph on YouTube.
So before you do the last question, do me a favor and type in our link to deukspine.com, deukspine.com/VC. V is in virtual, C is in consultation.
Copy that, already done.
Use this link and click on it, upload your MRI, and then give us some of your historical information, and then you can have a consult with me. Once I know what needs to be done, then we'll know what your insurance will cover.
Alrighty, this next question from Fred on YouTube. They asked, if you had RFAs that haven't worked or are getting less effective, will this procedure work instead for T10 level?
Yes, Fred, you are exactly correct. That's what this procedure is for. This is like an RFA on steroids. It is, I think, 10 times more powerful than an RFA. And when we kill that rhizotomy, when we kill that nerve with the rhizotomy, using this procedure, it doesn't come back because we're burning through the sheath of the medial branch of the dorsal ramus. So there's a sheath around the nerve fibers. You want to get the nerve fibers, they're called axons. You want to burn those. But if you burn the sheath as well, the nerve fibers will never grow back. The problem is RFA does not destroy the nerve sheath. Only the Deuk plasma rhizotomy does. So yes, this is the perfect procedure for you. If you've done RFA in the past, it used to be effective, now it's not. The reason it's not effective is you got more scar tissue around your facet joints because scar tissue comes from arthritis, chronic arthritis. And the longer you have arthritis, the more scar tissue you get. The more scar tissue you get, the less effective the RFA becomes. This procedure cuts right through the scar tissue and the little nerve that's causing all the pain. Thanks, everyone. You can go ahead and sign off.